Good evening, friends. As we know, since 2019 to today, we are seeing so many cases regarding the ARDS, and then we are familiar with the word ARDS. This is in stage. It will cause because of pandemic COVID H1N1, because these are the main causes for ARDS stage and all. Then in this cases, in this ARDS case, person will because of sudden respiratory blockage and all, it will collapse, and then they will take into the hospital. Then they will admit to ICU, and then they are doing so many invasive procedures and all. Let's we will start our brief discussion regarding what is the term ARDS, and then what is the stages, what is the main management, and then importance of prone positioning, and then ECMO pertaining to the nurses. We will discuss. We'll begin our discussion. Myself, Mr. Murugesh. I'm working in King Fahd Central Hospital. We will start. This is see whatever our we knows, no, that is an respiratory tract system. It will start with this one, nose, then it will comes to larynx, pharynx, then trachea, then bronchi, and then bronchioles, and then it's end with the alveoli. Alveoli is then structural and functional unit of the lung, in which it is an ARDS. It's a condition mainly it will affect the alveoli, and then because of the this one fluid buildup and all, no, person this alveoli it will getting bulged, and then because of the bulging and all, no, it can't perform, it can't work properly, and then person usually will get respiratory distress. Later distress, untreated distress, it will goes into severe, it will comes into severe, then person will attain this ARDS. ARDS means acute respiratory distress syndrome. We will define this one. See, as per Anson and Fletcher, that the meaning of ARDS is syndrome of acute and persistent lung inflammation with increased vascular permeability. It means what we know, no, inflammation. It is a body response in which whatever our vascular system, whatever that it will cause bulging, swelling. This all the things, whatever that our airway passages and all, no, it will getting swollen. Because of this one, patient will get respiratory distress. As we know, ARDS, it's a condition in which it is an acute condition. Means it is happening this ARDS stage, it will happen suddenly. It will come suddenly, and then in which person is susceptible to get respiratory failure or arrest, and then it may leads to cardiac arrest and death because of lack of oxygen supply and all, no, person can't breathe properly, and then he will get cardiac arrest, and then it ultimately it will leads to death if you are not taking adequate measures and all. See, this is the pathophysiology of the ARDS. When person will get lung infection means it's like fluid buildup, in which of a lung infection, it's mainly because of virus, bacterial, and then fungal, and then because of the massive blood transfusion, massive fluid administration. These are all the condition it will cause the stage ARDS. After fluid, once that whatever the alveoli it is getting bulged, means it will cause lung parenchymal dysfunction, whatever this, because of over fluid buildup and all. This all the portion, see this portion of the lung and all, it will get bulged. Because of the bulging and all, no, this all the whatever primary pattern, and then homeostasis, no, it will get destructed. Then after, once the patient means whatever our alveoli it can't do proper functioning, and patient will tends to attain this stage ARDS. ARDS means that acute respiratory distress syndrome. In this, no, patient need immediate management, whatever our some precautions. Otherwise, no, patient will get respiratory failure or patient will get respiratory arrest, and then respiratory arrest, secondarily it will cause cardiac arrest, and then it will ends up with death. That's why we have to focus regarding the ARDS. It's nothing but it's a stage. We need to it's nothing but ARDS. Simple meaning I will say you. It's like bulging of the alveoli, and then bulging of alveoli it will cause person to get some respiratory distress. These things are all the ARDS. Then next we will go to the some of the categories, whatever so many cases. See, this ARDS, it's a condition in which if we can say this patient is having ARDS. ARDS means you should have some particular symptoms like this ARDS stage. Usually it will be rapid, means acute in onset. Whatever acute means, this patient will go to the ARDS stage within 48 hours. Means before 48 hours he will be walking. He is doing all the EDLOs, whatever activity of daily living, everything he will perform. Suddenly he will get some respiratory obstruction, whatever distress and all. He will means suddenly he will get collapse. And then in the chest X-ray it should show some bilateral lung infiltration. Later I have the slides, I will show you. And then that whatever the PF ratio, it should come less than 300 mmHg. These are the three things. If patient he has these three characteristics, means we can say this patient is in ARDS, means acute respiratory distress syndrome. Means it should be acute in onset, means the onset of the symptoms, it should be less than 48 hours. And then chest X-ray, it should show some bilateral lung infiltrations. And then PF ratio, whatever partial oxygen saturation divided by FiO2, fractional inspiratory oxygen ratio, it should be less than 300. And then fourth more is no evidence of cardiac causes, like some of the things are there, some low EF and then pericardial edema. In these cases, this patient will have less lung expanding, whatever it is, some fluid overload and all. In these cases, this person don't have that history. If this history has, means there is some issues regarding the heart, like that, they will say, okay, this one you should not have any evidence of cardiac causes. Then this constantly rising high PEEP and FiO2, it means nothing but when patient is admitted to ICU or ER or CTBS, when patient is admitting, at that time PEEP is 8. Within 2 hours, this PEEP rate, if it goes more than 10, 12, like that, means this one they will consider it as an ARDS stage. And then usually that ARDS cases, that PEEP, it will be more than 10, and then FiO2 it will be more than 95, like that. 95% FiO2 we are giving through ventilator, and then PEEP it will be more than 10, like that. This is the thing. These are the characteristics of ARDS. These five features this patient has, means we can say this patient is suffering from ARDS, is in ARDS, like that we can say. Then what are the common causes for ARDS? There is two types, whatever direct lung injury and indirect lung injury. It means this ARDS stage, it will not cause only because of the whatever viral infection or bacterial infection or fungal infection. It can cause, it will be caused by secondary, like sepsis, massive blood transfusion, etc. Means for everything, it means I will say you something. For everything there is some limitation. If you are giving more and more, usually it can cause some destruction. That is the thing. See, in massive blood transfusion, if you are transfusing more and more blood within 3-4 hours, means a person will tends to get this ARDS stage. Then direct lung injury, and then whatever that our lungs, whatever our alveoli, it will it will expose to the causative pathogen, like that thing. This one direct lung injury, pneumonia, and then aspiration, inhalation injury, and then RTA, near drowning also, because of patient is in near drowning, and then patient will drink more and more water, and then he will get some aspiration and all. In that cases also, person will get ARDS. And then indirect causes like sepsis, because of secondary infection like bacterial infection and all, patient will get ARDS. Then massive blood transfusion, what I said before. This is the thing, because of more fluid blood transmission and then fluid administration, it will cause alveolar bulging. Then it will turns into the ARDS. And then there is three stages, important stages of ARDS. One is as per severity, and then as per severity of PF ratio. Means when based on the PS ratio value, they will categorize this one, ARDS. Okay, then first one, it is the mild ARDS. If PF ratio, if it is belongs, if it is in between 200 to 300 mmHg, means we will say this is mild ARDS. And then usually that common methods is enough to coming out of the this one, whatever symptoms. And moderate ARDS means it is in it's like it needs immediate attention per patient, means they have to take some measures. Like in that mild ARDS, and usually they will increase the PEEP, whatever, in they will do the low tidal volume and then high PEEP, like this ventilation they will do, like that they will manage. If moderate ARDS means surely patient need some prone positioning, like that things it's required. Then severe ARDS means it is one of the worst, and then it can cause person to die. That is the thing, patient to die. That's why we have to be more worried, we have to take more care of these patients. And all severe ARDS, if it is that PF ratio, if it is comes less than 100 mmHg. We will discuss little bit regarding PF ratio. PF ratio means nothing, it's like whatever partial, it's like you see, partial pressure of oxygen divided by fraction of inspired air, whatever, partial pressure of oxygen. See, this is the simple technique, simple thing I will say you. See the PF ratio. PF ratio means PF ratio, see, this is the whatever, see, this is the ventilator FiO2 divided by ABG PO2. Daily we are doing the ABG, that PO2 means partial pressure of oxygen divided by FiO2 means fraction of inspired oxygen. This is the thing, this is the ratio. PF ratio means PO2 divided by FiO2 into 100. This is the formula for calculating PF ratio. Whatever it is, our they are increasing daily, we are doing, no, this I think we are familiar with this. This one, when we are seeing doctor is, you want to adjust PEEP, you want to adjust, you want to modify anything in the ventilator, whatever it is, in order to change oxygen modalities, everything. This is the main, they are considering the ABG in that PF ratio they will take. If it is based on this value only, they will categorize what is the treatment modality, which one is the suitable modality, like that they will decide. Okay, PF ratio means PO2 divided by FiO2. This is the one example I will give you. See, PO2, if in that ABG it is showing PO2 value is 147, FiO2, whatever FiO2 means oxygen we are giving through the ventilator 50%, like that. If it is, see, 147 divided by 50 and then into 100, it means that this one value is 294. See, if 294, it is belongs to mild ARDS. In these cases only they will increase the ICU doctor, they will increase the PEEP, and then like that they will do the manage and all. If it is suppose that value, this PF ratio value, if it is comes less than 100 to 200 means 100 to 200 means it's the moderate ARDS. Then they will go for another modalities like proning, some ECMO they will discuss. In severe ARDS means if it is that PF ratio value, if it is comes less than 100 means it is very dangerous, and then in that immediate some ECMO or lung transplantation, like that they will think. It's all depends upon the intensivist or pulmonologist, they are the discussing. As in nurses we should have little bit knowledge regarding this. See, this one simple formula I will say you. See, comparing to 147 50%, instead of this one, no, we can use like this. See, this is the 147, instead of 50%, no, I'm taking only 0.5%. This 0.5%. See, 147 divided by 0.5, it means 294. This is the simple formula you can use. This one also very good, we can do the PF ratio under. This is the main thing, you just read this one, it's very good. PF ratio means 147 PO2 value, and then FiO2 50%. I am taking as I taken 0.5. See, 147 divided by 0.5, the result is 294. 294 means, see, PF ratio is 294, and then so it's mild ARDS, like that we can calculate. This is the PF ratio calculation, it is one of the main thing. Then diagnosis, how they will diagnose the ARDS. There is some difference, there is so many. In the X-ray also we can see infiltration, consolidation, so many things are there. We will discuss. For ARDS, no, for diagnosis main is examination of the airway. Auscultation, where if you are auscultating means we will hear, we will, if in case of patient is having fluid overload means we will die, means we usually we will get craps like things. If more secretion because of ARDS whatever is more fluid accumulation means we will get wheezing and all. This is the thing, like that for the examination of the airway it will helpful to diagnose the this one ARDS stage. Then throat swabs are nose swabs. This is mainly because of identify the virus, which virus, and then whether it is pandemic coronavirus or this one H1N1, like that. For categorizing, that is very useful. Lab investigation mainly CBC and pleural fluid, because CBC means neutrophils. This is the condition, means these are the things during viral infection and all, no, it will be high. Even if secondary infection and then WBC, everything we can consider which one is the causative pathogen, everything we can came to know. Then pleural fluid analysis usually because of overswelling this one alveoli and then any that pleural edema, in order to rule out they are using the pleural fluid analysis. Whatever, these are all the things it will be said by the pulmonologist or this one ICU doctors. There are the things. Then chest X-ray, usually chest X-ray or CT chest to determine if there is any fluid in the air sacs of the lungs. It's, as we know, ARDS, it is then condition in which alveoli is bulging. In order to rule out, CT is the main, HRCT or chest X-ray, it is showing, see, these are all the consolidation. Even we can see like this, some spots will be there. ARDS means whatever infiltration, everything we can see. And then one more, this one slide is there. There we can, I will show you what is the infiltration, everything. Okay, these are the thing for they are using for diagnosing the ARDS and all. Then main treatment for ARDS is they are using antibiotics. Antibiotics means usually they will prefer for azithromycin because it has very good effect for this one upper respiratory infections and all. That's why they are using. Then blood thinning medications are AIDs. This is one of the main thing, because blood thinning, no, if you are not giving means clot, because the clot, if it is enter into the heart means usually it will block the complete heart circulation, whatever cardiac circulation and all, person will get cardiac arrest. That's why, okay, this is the main thing. Whatever our doctor, if they said to give this one blood thinning medications and all, no, we have to give properly. That is the thing. See, this is the example for blood thinning medications are heparin. Then compression stockings, like if usually viral infection, no, there is usually that platelet count will be low. In those cases, no, if it is less than 20 and all, no, they will prefer to use some test stockings, DVT stocking, DVT compressors, everything they will say. That one we have to use it as a this one, whatever anticoagulants like that. Then nutritional support, it is the main thing. Whatever, in order to come out from the infection, we need some good nutritional support in order to maintain normal and micro and macronutrition balance. Then if all the things, the three things along this one, if because of alveoli swelling, usually this whatever viral infection and whatever our corona, whatever it is, H1N1, it will take 14 days to heal, complete healing, and then whatever complete recovering from the viral infections and all. That's why we need some time, because it's happening suddenly, no, we need to give some oxygen supplementary oxygen therapy. Without oxygen, it's very difficult to manage the patient airway and all. That is the main thing. In that oxygen therapy, usually based on severity of this oxygen requirement and all, we will go with nasal cannula with 1 to 5 liter like that. Then if patient is not tolerating, still is getting the respiratory distress, means if saturation is not maintaining, means then we will go to face mask. Face mask usually 5 to 10 liter we will give. If it is patient requires further more oxygen, means we will go to NRB, non-rebreather breathing mask we will go. Then if more than 10 liter also we can deliver with this mode. Then if still is not maintaining, means then they will go to HFNC, high flow nasal cannula. In that up to maximum, if he still is not maintaining the saturation, means then they will connect to BiPAP more, we know, CPAP, then on PCB, like that they will connect. Same NIV also same, then they will go to NIV. Still if patient is not maintaining saturation, if is not doing anything, means that the saturation is dropping, means they will do intubation. See, this is the high flow nasal cannula what they are given. Then One more thing, for usually for treating whatever this viral antivirals, they are using very less cases, because viral infection for a certain period it will go easily. That's why they are very less time they will use. Usually some of the this one fluir whatever they are using for H1N1 and all, but very less times they will use for treating ARDS and all, antiviral and all. See, this is the one iflow-nasal cannula they connected, and then this is the flow rate. Again, you can see the monitoring everything. As in nurses, we are seeing everything is there here. Then another treatment, this one ARDS management, it should as per the policy, it should have some this one things. It means treating underlying causes. Suppose if ARDS, it's like syndrome, this word, that meaning only, definition only we can know. ARDS means it's in syndrome of, it's like syndrome of infections, whatever, syndrome of diseases. Means it can cause ARDS. Again, patient will get because of, he will get bacterial infection, then he will get sepsis. Sepsis, again, it will lead to diabetic ketoacidosis. Then nutrition imbalance. These are all the things because of ARDS and all. Because nutritional imbalance means because of person intake, everything it will be decreased. That's why you will get. And then diabetic ketoacidosis means because of more and more this one acidic, whatever that is, as patient will get acidosis. Then because of this one, patient has diabetic history, means usually you will get diabetic ketoacidosis because more ketone body's production and all. It will provoke this ARDS stage. Then sepsis also, it is main thing. Because of sepsis, patient will get diabetic acidosis, like the thing. In order to treating, this is also one of the main. Then lung protective ventilation means, as I said before, low tidal volume and then adequate PEEP. It means tidal volume means it's like amount of air entering into the lungs in each breath. PEEP means positive end expiratory pressure. We are putting some pressure to open up the lung, whatever, because of swelling and all. We are giving some external pores through ventilator in order to open up the this one alveolar sac. That's why this is the one. This one they are using usually when patient is in ARDS stage, means they will use low tidal volume plus adequate PEEP. Usually that tidal volume they will set less than 400, and then PEEP up to 14 they will increase. Up to 14 they can increase to PEEP, means high PEEP and then low tidal volume ventilation. This is also one of the good lung protective ventilation, means it's lung ventilator mechanism. Then avoid a positive fluid balance. Again, already alveoli is bulged. Again, if you are giving more fluid, means again it is no sense. That's why they will say we need to keep negative balance. Then however, in severe cases, means cases of ARDS, if PF ratio, if it comes less than 200, less than 150, means low pH, low this one oxygen, low saturation, and then high CO2 and increasing PEEP pressure, means all the standing, whatever our antibiotic, whatever our antibiotic, the nutrition support, oxygen therapy, it is failed, means then we have to go for prone positioning. See, this is the first day of infection. That why ARDS patient first day X-ray. See how much clear ears. See, ear full of infiltration. This all the infiltration. See, you can see the infiltration. Again, third day you see. Again, fourth day you see. Again, fifth day you see. Again, sixth day see. Like this only up to 14 to 15 days. When patient is in ARDS, he will get like this X-ray. If it is completely lung collapsed, means it's very difficult. It's very difficult to manage, and that's why in order to avoid this one, in order to keep this one good this one cardiac circulation, everything, they will prefer for prone positioning. We will discuss one of the main therapy we are using in the ICU, that is the prone positioning. We will discuss regarding this prone positioning. See, prone positioning, usually it's indicated, means in these cases prone positioning is indicated. See, suppose patient PEEP and FiO2 is increasing, and then if it is a PF ratio, if it is less, if it is dropped less than 300, less than 200, like that. Prone positioning, if PF ratio falls below than 200 mmol. If prone positioning, sorry, it's what is the thing? This is the another modalities for the treating ARDS. One thing is, if PF ratio is less than 300, means we can increase the PEEP. We can if we can adjust with the PEEP and FiO2, we can manage. If PF ratio, if it is comes falls less than below than 200 means we can use this prone positioning. If suppose if PF ratio is less than 175 means we have to go for ECMO. ECMO means usually VV type, venous to venous type of ECMO we are using. This is the most familiar what we are using since long days. Usually Australia and all, no, they will prefer, they won't do the prone positioning, directly they will go to this ECMO. Then lung transplantation, no, this is also one of the, if PF ratio falls below than the, another alternative for ECMO is the lung transplantation. But lung transplantation, no, it has so much limitation, because we should for this is the, anyway this ARDS is in suddenly happened, and then lung transplant for this one, it is this one suddenly happened, and then it can cause, because this lung transplant is not feasible, because in order to do whatever transplantation and all, now we need to select the donor, everything. That's why they are rare cases they are using the this one lung transplantation and all. Only this prone positioning, ECMO, these two are the main treatment modalities they are using in hospital. Most of the hospital they are using lung transplantation, so they are using, but very less times they are using. See, this is the ECMO machine. See, in that two catheters will be there. Here one for this one superior vena cava, one for inferior vena cava, like that. Whatever our dialysis machine is there now, like that, it will purifies the blood. Like that. See, this is the whatever that purifier or whatever dialyzer, it will act, and then see, like this patient will get good adequation, and then it will maintain the oxygen homeostasis. That is the thing. Later one time we will discuss regarding the ECMO. ECMO means nothing, extracorporeal membranous oxygen. That is the thing. VV type of ECMO. Extracorporeal means whatever that lung function, no, it will be done by this machine. That is the thing. That is the meaning of this ECMO. See, prone positioning. This is the we'll discuss. Main indications for this one is prone positioning is ARDS. Person should have ARDS. Then this onset of the history, whatever that respiratory distress, it should be less than 48 hours. And then PF ratio, it should be less than 200. These are the three characteristics, whatever that indicators in these cases we are using. Then relative, some of the contraindications is there for this one. Whatever this is. Contraindications for prone positioning is there. That one first one is elevated ICP. Means if ICP is more, means they will not prefer. Then intestinal ischemia, obesity, recently patient undergone any abdominal surgery, means this prone positioning is contraindicated. Just see this one, like this only they will do the prone positioning. Even for non-intubated patients also they will use this one. If patient is on HFNC or patient is on rebreather mask and all, no, they will prefer, because what is the thing? No, main thing is if you are bending, no, if you are giving like this prone positioning, means whatever our posterior aspect of the lung, whatever lung parenchyma, alveoli, it will functions properly, and then this whatever our this one lungs will not get overread because of diaphragm and heart. That is the thing they are using the prone positioning. Then absolute contraindications for prone positioning is if patient has spinal cord instability, then unstageable facial fracture, then anterior burns, open abdomen, then increased abdominal pressure, then unstageable pelvic fracture, even pregnancy. These are all the contraindications for prone positioning. Okay, these are all the common this one. Prone positioning. What are the indications? See, usually moderate to severe ARDS, and then early 48 hours, whatever we discussed before before this one and all. Then duration, based on this usually that prone positioning, no, usually they will whatever our intensivist and then pulmonologist order we are carrying. Suppose usually 12 to 20 hours it's recommended, but up to 24 hours they will keep, based on the whatever ABG PF ratio. If it is PF ratio is very less, means usually they will keep up to 24 hours, like that they will keep. Then prone positioning. What are the benefits of prone positioning? Then improves the perfusion to the lungs. You know, See this, in this we can see when patient get infection, only this anterior aspect, no, this aspect get infected, and then this one, this alveolar portion, no, it will get bulging, and then it will get whatever swelling and all, it will not function properly. Whatever posterior aspect, see this one, this thing of the alveoli and all, no, usually it will not work. Usually it will be free, they won't get infection, whatever swelling and all. That's why if we are keeping this one down, and then means anterior portion will be down, and then posterior portion will be in up, means usually that posterior alveoli, it will start, will get into work, and then it will function properly. Like that we can save the person's life. Usually we knows this prone positioning, it's in a life saving measure, whatever modality. It's not in treatment, it won't improve the this one whatever, it won't decreases the that alveolar swelling and all. Usually what is the thing, no, what is the benefit of this prone positioning? Prone positioning means it is a life saving method, because already patient whatever posterior aspect of the lung parenchyma, no, that alveoli and all, it will start to work, and then tends to maintain the normal circuit, whatever normal breathing mechanism and all, it will maintain. That's why they are using the this one prone positioning. Even one more thing, like this, that backward positioning, no, it will improve, it will draft the diaphragm, and then heart shift to forward. Like this also it will improve the lung compliances, means it will avoid the extra pressure on the lungs, and then again heart can this one lungs can freely do the expanding, whatever recoiling, everything they can do. Like that it will use, this means it will improve. Then improves the lung recruitment. You know, when the infection gets means when the infection is in peak level, whatever alveoli everything, no, completely it distracted because of more fluid build up and all. Once if you are giving some times, if you are giving adequate antibiotics, then antidiuretics, and then if you are giving good this one PEEP level, CPT, everything, means that whatever our anterior aspect of the lung parenchyma, it will get improved. That is the thing. Lung recruitment means rejoining of alveoli into breathing. That is the thing. Means again alveoli, it's coming back to their work. That is the thing, lung recruitment. Then this is lung protective. See ECMO and all, no, usually it has more this one. What will say? It has more side effects, and then it can cause some injury, lung injury, everything like that. And then in expensive also, this is ECMO procedures and all. This lung protective, that's why they are preferring for prone positioning. Lung protective means because of only invasive thing, no, sorry, it's a non-invasive thing, no, this one bending, this one we are not inserting any tube, anything into this one, no, that's why it's a lung protective. It's a simple measure. With this we can protect the lung. That is the thing. Then another one more, few more this one indicates that whatever improvements of this one this one is may lower airway pressure, may improve tidal volume and minute ventilation, because this one may improve tidal volume and this one minute ventilation, because we are backward positioning, no, this one tidal volume will get improved, and then minute ventilation, whatever the secretion, everything, it will be getting decreased. Like that reduce the risk of atelectotrauma, barotrauma, valvulotrauma. These are all the main things. Means they are the indications for prone positioning. Means prone positioning reduces the risk of atelectotrauma, means that alveolar injury, then barotrauma, lung injury, valvulotrauma, this whatever the total volume, this one it will get trauma, no, this all the things we can prevent because of using this one prone positioning. May improve tidal volume and minute ventilation. Usually whatever the how many cycles, everything, it will be decided by the physician or intensivist, whatever pulmonologist. These three persons, they will decide which how many cycles we need to do. Usually 6 to 14 cycles they are using, because usually that within 1 month that viral infection, whatever our corona, whatever everything, no, it will go. That's why usually 6 to 14 cycles it's enough. Like that the most of the pulmonologist and intensivist, they are saying it's everything, it comes on this one pulmonologist or intensivist discretion whether we need to continue or not. See, now we will discuss little means main thing, our nursing care we will discuss. See, when patient is on prone positioning means ensure it's the basic thing. Already patient is in this one means we have to ensure adequate sedation and analgesia. If it should be, we should maintain a good sedation. The TRAS score it should be -5, because even mild coughing also it will further distracts the alveoli. That's why usually that our doctors they will say us to keep RAS -5, like that means analgesia, whatever that sedation, whatever muscle relaxant we have to use. Then securing all lines and tubes, so avoid interruptions, because usually the patient is in prone positioning means there will be sedation, there will be, because of sepsis, there will be, patient will be in negative inotrope, so many things. While doing the whatever positioning and all, no, we have to be avoid interruption. That is also one of the thing. Then ABG PRN to assess oxygenation, ventilation, PCO2 and VBG one style. VBG means in order to know if VBG, PCO2, everything we need to know, no, that's why they will VBG also we have to do, because VBG saturation and then ABG saturation, no, usually our intensivists they will compare which one is good, which one is like that, they will decide for further treatment modality. That's why once in a VBG it's mandatory. Then ABG PRN, suppose patient in prone positioning, saturation it's came less than 80-85%, immediately we have to do the we need to do the ABG. Then repositioning of arms second hourly, and head positioning changing fourth hourly. These two are the main things. See, when we are keeping patient in the prone positioning, usually see like that positioning we are doing, prone positioning, usually that hands, no, we will keep like this, we'll keep in upper side, means above than the head, because like this patient will get, so what we'll say, patient will not get adequate perfusion in the arms and all. If there is no good circulation in the arms and all, no, patient will get ischemia, he may chance to get ischemia and all. In order to avoid, we have to reposition like that it will be their hands like that, in the above than the head they will keep like this. We have to reposition like this in between second hourly we are moving like this, means no, it will improve the circulation. Head position change bits in order to avoid some facial this one injuries and all, no, whatever bed sores and all we are using, and then even it improves the circulation like that. Fourth hourly we have to do this as per policy. Head position changing we should do in the every fourth hourly, and then arms we should do repositioning we should do every second hourly. Then nutrition, usually that minimal feed therapy, because patient in backward position, and then even stomach also getting into the this one compressed state. That's why usually minimal feed is required, please 10 to 20 ml. It's all everything because of that dietitian and then their management. Just we should maintain minimal feed therapy. It is good to reduce the risk of aspiration and parenteral nutrition therapy. This is the thing. Parenteral nutrition therapy, if suppose patient is getting more aspiration, more GI aspiration, and then if patient is if patient is if he has some GI disturbance and all, no, they will go for parenteral nutrition therapy, whatever TPN and all they will start. Check Q second hourly for pressure area, whatever. If the patient is in backward position, no, we have to check oftenly, we need to second hourly we need to check whatever that pressure proning areas. Then family education, this is the most important thing. When patient is in prone positioning, whatever we will say that backward positioning, no, usually patient relatives they will getting into the scare, and then they will get panic. That's why in that time we have to do some counseling and all everything. These are the main nursing interventions. Then this is the thing when how they are doing the proning and all. See, usually that's the center person, he is the one, usually respiratory therapist or doctor, they will hold the airway. 4 members required. See how they are taking one side corner and they are taking, and then they are keeping this one smooth pillow in this one, and then usually facial support they will keep one this one soft pillow on the this one head, whatever face and all. Then slowly they will take into this side, and then they will turn. See, they did prone positioning, and then see here they are doing, and then in that, no, after prone positioning we should give this one reverse Trendelenburg position, means that end position, means total this one, no bed, no, like this we need to keep like this, because if you're keeping down, no use, and then that secretion also it will not getting clear. That's why we have to give. Usually that head end of the bed it should be 20 degree head end elevation, 20 to 30 degree head end elevation is enough, like that is there. Then see, when after doing this one all prone positioning and all, we should monitor vital signs and urine output, then minimal NGT or OGT feed, then check frequently plateau pressure and P peak in ventilator. Means these are the two indicators. One day we will discuss regarding the ventilator and all, then we will learn everything. We can learn. See, plateau pressure and P peak. These are the two alarm. If patient is having any secretions in the tube or any blockage, means this one will go to more than 38 plateau pressure. If it is goes more than 38, P peak also if it is goes more than 38 means it indicates that there is some more secretion in the ET tube. Then that clearing the airway means whatever it is. If P peak plateau pressure P peak is high means we should do ET sectioning. Then frequent dead portion and on portion changing, this is also important thing. Approach doctors for daily for chest x-ray in order to see the improvement, whether it's improving or it's down going, everything. It is also one thing in whatever in ARDS condition, this chest x-ray and ABG, these two are the main things. If we, with this only we can know what is going inside, everything we can means that doctors can decide which modality is good, like that. Even electrolyte balance also, it is one of the good testing. Then ABG, regarding ABG, before means 1 hour before doing prone, means suppose doctor they said we will be based on ABG only, we will say, see, we will do ABG. We have to do 1 hour prior to that, means prone positioning, 1 hour prior we have to do ABG. Then after proning, within 1 hour we have to do, means in order to see the improvement, whether that backward posterior alveoli, whatever lung parenchyma, it is functioning or not. In order to know that one, we should do ABG after, means ABG after 1 hour. Then prior to proning, we have to do 1 hour. 1 hour before we should do ABG. After doing proning, within 1 hour we should do the one ABG. Then after supining, once patient is supine means within 4 hours we should do ABG in order to know whether that anterior aspect of the lung parenchyma it is working or not. We can know like this. Then 6th hourly ABG, daily RFT required as per physician order. As per physician order, we should do ABG 6th hourly and daily RFT. It's all by the that physician, whatever our intensivist and then pulmonologist order. These are all the things we can say. This is the whatever that ARDS stage, and then it is a simple brief discussion. This is the one main thing. It's main thing. We can this is the main thing. Nursing management. We should know. This is the whatever ABG. Be 1 hour prior to the this one prone positioning. After doing means after 1 hour of prone positioning, we must do the ABG. Then after that, once we did patient supining, means we should do the ABG. This is the main thing. We need to assess the lung condition and all. Okay, I think you will get little bit idea regarding this one prone positioning, whatever our ARDS stage and all. Just you try to see this one. Okay, thank you for all. Thank you for watching this video. Thank you so much. Thank you.